Hi, and welcome to everyone to the second day of the AfroPHC conference virtually. So we really glad to have our presenters showing up today as well. So let me just quickly put that up. So welcome to the second day of the AfroPHC conference. We are glad to have our panelists hopefully back, as well as some of the key people that could provide us feedback from yesterday. We hope that the participation will be as good, if not better, than tomorrow, than yesterday. So I want to just say that, sorry, thanks. We just need to remind you that you can use the French translation if you need. Alexandra is available. If there is some French that's being spoken, you can also go there and get English translation. She'll do that. So click on the interpretation and choose English. We have our president who will do some quick introductory remarks. And then I was hoping for Professor Anna to join us. Otherwise, what we're going to be spending the rest of this afternoon will be to get feedback from the various group discussions yesterday. We had a really enjoyable, stimulating panel discussion, and we hope that the group discussions actually produce some more insights, some more thoughts around how we may go forward with this policy framework, building the primary healthcare team for UHC in Africa. So with that, let me hand over to Dr. Innocent Besigye, who's the president of the AfroPHC, to welcome you, and then we'll continue. Thanks. Over to you, Dr. Besigye.
Yeah, thank you once again, Professor Shabir, for again making this happen. Once again, dear participants, allow me on behalf of the African Forum for Primary Health Care to welcome you to the second day of this virtual conference. Again, it is never our wish to meet virtually, but that is what circumstances demand. And I think we need to always do our best to make sure that we come together and develop a common vision for advancing PHC on the African continent. Allow me to congratulate all of you who were with us yesterday for completing yesterday's discussions and the tasks. And you agree with me that the presentations and the most important of all, the group discussions were quite fruitful and insightful. And I think we are on a positive track on getting ourselves ready to have what will guide us in advocating for PHC on the African continent. Yesterday, I really would like to apologize. I forgot to acknowledge the presence of some participants from our supporting organizations. And I think today, allow me in a special way to welcome all of those participants who are coming from all of the organizations all over the world that are supporting the African Forum for Primary Health Care. And I think the most important thing is not us to give speeches, but to really spend much of our time putting our heads together and seeing how we can properly understand and advocate for primary health care. Again, allow me to wish you fruitful deliberations in the next 2-3 hours. And we are hoping that by the end of today, we will be on the next level as far as advocating for PHC and also implementing and guiding the development of primary health care on the African continent will be on the next level. Thank you once again. I wish you all the best in the next 2 or 3 hours of discussions. And please, I encourage you to actively participate both in the plenary discussions, but most important of all, in the group discussions, because it is through those group discussions that we actually get new ideas and that will help us to steer AfroPHC to the next level. Thank you very much, and you are very much welcome. Over to you again to Professor Shabir for the next activity.
Well, thank you very much, Dr. Besigye. I think we Do acknowledge also the executive board members that have joined us, as well as advisory board members that have joined us. We really appreciate that you've taken our time to be with us. We're going to start with, I think, the ones that I can recognize. I think we just need to get the facilitators from yesterday just to rename themselves. But I see Jamie Colity, who is a young doctor who's working on the in the executive coordination team, who I think was facilitating a group yesterday. Dr. Besije, I think you also did the same, so you might be able to also provide us feedback, Dr. Besije. So we'll just rename anyone who was a facilitator, yesterday, to just do that. I'll just rename. So Dr. Besije will also give some feedback a little bit later. And then we'll just get everybody else lined up so that we can get some feedback. There were about 4 or 5 groups. So let's start with
we actually also had Dr. Eli Bajo, who was our rapporteur, I think.
All right, that'd be great. So if you can call him out, we can just, I think Eli fell off. Maybe he was here just now. Oh, there he is. So
and
I'll
then,
just...
then you can also make Razia the co-host, because she's actually the one who took the notes.
Who is Eli and?
Razia.
Ah, there we are. Thanks, Razia. So I'll just make you, I'll just put in there, but we'll allow people to all unmute. If you can just avoid, you'll unmute now, but just please avoid doing that unless you're speaking. So if you are needing to speak, please raise your hands before you unmute yourself. Thank you. So shall we start with Jamie, or do you want to go with Razia? Let's start with Razia. And then Jamie, if you're okay, we can just you can just point out who will be the person in your group to actually do that. And as co-host, you can actually rename. I think all of you can rename. So feel free to rename yourself with an F, so we can actually make you be clear that you'll be providing some feedback. Good. Let's start with Razia. Thank you very much, Razia. Perhaps a quick, short introduction of yourself. I think profession, place of work and country would be really good, and then you can continue.
Thanks, Prof. So I'm Razia Khan. I'm a pharmacist and I'm from Wits University.
Wonderful. Proceed. Thanks. Please give us your feedback.
Thanks, Prof. So our group actually started deliberating and then decided to just introduce how primary healthcare is done in each of the countries, so we could have an understanding for how it was different before we carried on with the deliberations. And what came across was that most people felt after explaining to us, and it became very clear that it's done very differently across the countries. While there were similarities, it really helped us to understand how to go on further in terms of recommendations and in terms of what we did and did not understand. Mm-hmm. So mostly everybody felt that it was an important initiative and that the guide was a good document basically to guide countries on how to go about with implementation. And also most people felt that it would be good to have a model delivery site that was operational, that could be used to show other sites how to operate, basically. And also there was a general feeling that it was not easy to understand the model of the community in practice, and also of how the interprofessional education part would work. I think by and by everybody felt that the document was comprehensive and it captured all of the issues, but really that models of care should maybe be shared more. And then there was also some recommendations that came out, that as we were deliberating, we had somebody come into the meeting to perhaps give us more clarity, because people were feeling that the document actually wasn't encompassing everything. And then it was made known that it was a policy and a concept, and that the countries would have to adopt the document according to their human resources and their way of practicing. So it was felt that maybe the document must be adapted to a more local context, and maybe countries could give examples. Sorry, excuse me. Countries could give examples of how it would work practically in the different countries. They also felt, our group also felt that there were some things missing in terms of inclusion of mental health and what resources would be needed to encompass that. And also that across the board, it seemed as if though the community health workers were not incentivized enough, in that they were not always remunerated. So there was this feeling that in some cases, it was recognized that community health care workers were important, and they had that in their communities, that they were important people because they were selected by their communities to do this kind of health work, but they were not remunerated. So there was a recommendation that some sort of formal remuneration should be encouraged to incentivize community health workers to maybe do the job better. There was also a recommendation and also some experiences that came through when remuneration was provided. And they also felt that when it's done piecemeal, it also then discourages people, because they feel that in certain cases they do get remunerated and in others they don't. So then there's no incentive to work when there's no remuneration. So those are just some of the things that came across in terms of finances. And also, they felt that if there was a standard remuneration, it would motivate the healthcare workers to be maybe more proactive and participate in the services that they needed to carry out. And then we also discussed that perhaps also in some ways the community should also be encouraged to be responsible for their health, and to sort of work something in where we could capacitate the communities also to become responsible. So giving them some sort of accountability for the process. And then another interesting recommendation that came up was that it would be useful to have sort of a mapping of the trained healthcare workers, of where they were and what they did, so you could understand where the resources were, and then obviously map it against the geographical area and see which areas were under-resourced.
If I may just clarify, is it healthcare workers or CHWs?
The community health workers.
CHW.
So as they were trained to map where they were actually, in which communities they were. And then also there was a case, people spoke about in their different countries, how their resources were different, and how in some cases where the primary care is not functioning due to the lack of resources, and where patients are then were not willing to attend the PHCs, but actually go directly to the hospitals. And that, felt that if the community health workers could be used as a resource to encourage communities to attend the primary care clinics, and then to attend to the building up the resources in those primary health care clinics. And then, at one stage, the sound wasn't too good. And I'm not sure if I heard that traditional healers were not included, but I made an asterisk against that because I needed to confirm that. But those were basically the deliberations that came out from our group. And if anybody wants to add anything from our group, please do, if I've forgotten anything.
Wonderful, wonderful, Razia. I think, really important insights about the variation of PHC. I think it's just a problem we've got to address. But I mean, there's a lot of commonality, which I think you picked up on by way of the shared thinking. I mean, the model site would be useful. I think we can talk about how we make sure that this community practice idea and some of the ideas become a bit clearer. And I think your recommendations are really spot on. We'll just look at how we assimilate all of that. But I think there's plenty for others to reflect on. So good for you. Thank you. Is this group 2, Razia, if I may just be clear about that?
Do you remember that group 3?
Group 3. All right. Great. Thank you very much. And I don't know if any other, like Innocent earlier, anybody else would like to add to that conversation, or as Razia captured it fairly fine. you feel the need to add, you can just add some comments.
Yeah, I personally, I don't think there is anything to add. That is what the group discussed, unless if Eddie has anything else to add. But from my end, really, that was comprehensively.
Razia did very well. Thank you. Ellie, anything to add?
No, anything.
Captures well.
It's good.
Just to check quickly, have you managed to record the session? Because, you know, did anybody record it? I think you did, sorry. The recording was sent by Innocent. Well, thank you very much, Innocent. Right, I've got that. Thank you very much. So I think we can just try and capture them better and just assimilate some of the comments that might have been missed out. But thank you very much. Great to have you here. To those who've joined us now, thank you. We basically begun to get feedback from the various groups. The recording for yesterday's session is on the web page, so you can have yesterday's session, and today's also will be there shortly. You know, if not during our conversation, that it'll be there. So thank you to group 3 that was presented. The rapporteur was Razia Khan, who shared this, the insights to this. I don't know if there are any, well, let's go through the groups and then we can sort of open it up, get some panelists. So let's go to the groups. I'm not sure if there are others that were facilitators. Jamie, your group, which group was that?
Hi, Prof. So I was part of group 4, and we actually had Magdalene as our rapporteur. I don't know if I can maybe speak to some of the points that we made, and then if
she's not here today.
She's not here. Okay.
All right. I'm not sure. Just I'm gonna just check. She's not. Yeah. Oh, no, there's Magdalene. There you are.
Magdalene is here.
Let Magdalene present. And
Magdalene.
Yeah, she's here.
That's great. Magdalene, great to have you. I'll just quickly, you know, I think we'll just go ahead, Magdalene. Feel free to, and then Jamie will add to your comments.
Jamie, you can add. Is okay. She can start.
Not a problem.
Okay.
Great.
Okay, so maybe. Okay, Magdalene, so then maybe I'll just speak to what we spoke about yesterday, and if there's anything that you feel I have missed, feel free to add. So in our group, we discussed, so we gave the group a bit of time to look through the policy document. Some members weren't entirely familiar with its contents, but some of the things that we spoke about in the group was that it was suggested that it would be helpful to have a standard definition for PHC. That helps with.
Sorry, Jamie, you seem to be breaking up. I'm not sure if you're moving around.
Just kind of standardizing everything. Standardizing countries do have different ways. Often countries have different, a lot of emphasis on they do, which we also saw was quite varied in different regions. And there was mentioned that with the use of community healthcare workers and other members of the MDT, that one of the key things that needs to be emphasized is communication. And for members of the PHC to know their roles and know their capabilities and communicate with one another to provide this comprehensive care. And there were suggestions to include lab staff as well. And then we spoke quite a bit about the suggestion.
Sorry, I think let me just stop the muting because that's the problem. People unmute.
Okay, sorry.
All right, so just go ahead.
Sure. Then there was some discussion regarding data management within PHC. So there was just some talk from some members about how often PHCs collect lots of data, statistics that we feel like isn't always being utilized. Statistics on the demographics of patients that are seen within the PHC, and a few members said they're not actually sure where that data ends up going, and it's this huge, dense resource that we really can tap into and use. We just need to utilize it to its capacity. So we spoke about that. And then
Sorry, Jamie. Jamie, I think you're not coming across, Jamie. If you can.
Contributions on the parts are quite exciting and something to look for. That was the main points.
Jamie, sorry, we missed the last 30 seconds. If you just don't mind going back 30 seconds, sorry.
Oh, sorry. The signal's quite bad. We have load shedding in the area,
yeah,
so the signal's quite bad. So I think I had spoken about data management and using the
no resources. Feedback. Yeah, that's right.
Yes. And then we also touched a bit on the part about e-health and how everyone agreed that that was quite an exciting thing that we needed to potentially tap into and discuss, particularly within the African context. Right. But overall, there was good feedback. Most of our members reported that they thought that the policy document was very extensive and well written and well explained.
Right. Good. Well, thank you very much. I hope that we've caught all the issues. I think that the initial idea that the variation is really a big problem which we have to begin to deal with ourselves. I think there are avenues and issues. In fact, last night I was just reflecting on the fact that Jeff had raised the question that there is already a fairly standard definition of primary health care. And then at the same time, there was a statement on Friday last week by the Lancet chair, Lancet Commission chair on financing that is not so clear. So I'm keen that we begin that. We have a research project to begin to do some of that. And I think it's a big challenge. But I think you point out in the rest of it, to the question that, well, the document's useful, but clearly, this communication roles and responsibilities is about teamwork and how we make that happen. Lab staff, I think, we can actually find ways, like has been mentioned yesterday, to make sure everybody possible is mentioned in a way that's like an addendum. These are all the different people and we're talking about all of them. So we need to do that without crowding the document. And I think the point you make about data and e-health are very relevant. So thank you, Jamie, for that. I don't know, Magdalene, if you wish to add anything to that. You probably took some notes as well. Magdalene, feel free. I think I just make you co-host so you can share. Magdalene, go ahead. You can unmute yourself, Magdalene, and you should be able to speak.
Okay. Yeah, thank you. Jamie has put it very clearly, and we were able to see that this document is very good. What we want that to be clear is every role of every personnel. It's very important. So it's very clear. That's what Jamie has spoken out is what we captured yesterday. And we came up to see that community health workers are very important. We have seen with the pandemic how they help and they reach where doctors, like we know we have marginalized places in Africa where these community health workers work, the nurses. So it's a teamwork and good communication and data management. Thank you.
Wonderful. Thank you. Thank you. Important point. Great. Well, I think, there's a strong consensus here at the moment that the document does serve a valuable departure point. Obviously, lots of issues that can be changed about it. And I think that's really what we want to see, how well it can be improved. And I think it'll be an ongoing improvement. So let's see if there are any other groups that maybe I could just turn to Mercy. Mercy. Has Mercy fallen off? Oh, Mercy, if you don't mind, just seeing if you can, if you can just help us to find the other groups.
So we've had from room 3 and room 4. So we had room 1. Ahmed has not joined today. He was a facilitator for room 1. Right. So I don't know who from room 1 will be giving feedback. Room 2, we have Al-Mughira here.
Al-Mughira, yes.
For room 2, we have Al-Mughira here.
All right, great. Let's get Al-Mughira to give us some feedback. Al-Mughira, will you do that, or do you have somebody that you think is the group that will do that? Al-Mughira?
How are you? And good afternoon for everyone. First, let me congratulate all of us for the wonderful starting of our conference yesterday.
Right.
And unfortunately, Dr. Uje, who started yesterday to be the rapporteur of our group, I haven't seen her name.
Hajij, is it Redwane Hajij?
Yeah, no, Uji, I think.
Uji. All right. Okay. Not a problem.
It was Dr. Oge, and she's not in the meeting today. Yeah.
Now, unfortunately, she's absent today to some reason.
No problem.
But I can make some summary for what is was going on yesterday on our discussion, and then I will let the chance for Dr. Umar. He was one of the prominent discussor yesterday. He has very, very, very important recommendations. I will just give an overview of what is yesterday was done. Then I will let him clearly stating his recommendations. Okay. First, our group yesterday had a very fruitful discussion, and I think most of the members were engaging in the discussion, but some of them were having problems with the communication or with the connection. Sorry. And but the discussion really was fruitful, and most of the discussers, or the members of the group, they said or they said clearly that the document is very beneficial, and they appreciate what is done so far, but they have some remarks. The most prominent one was regarding the community health practitioners. They say that they are not included in they stated clearly in the document, and it should be there. And they say that they are the backbone of the health system in many African countries, especially Nigeria. So they say that this is a good chance to add them to the document. And also there are some reasons for that, because they say that there are shortage of manpower in healthcare cadres in general, and they fill the gaps. So they have to be included, and they have to be motivated, incentivized, and encouraged to participate in the health system, especially in the universal health coverage in Africa. So they recommend that they have to be the community health. They have to be given the right to participate in the health system or to be a part of this document. Also, they talk about the political will. This should be clearly stated in the document, and how are we going to address this issue, the political will of the. Also, the discussion gave great room for the health financing for primary health care in Africa, and also the experience of Nigeria also come on top of the discussion, and people say that there should be clear pathway on how to make the policymakers raising or increasing their contribution in the healthcare financing, especially in the primary healthcare. And it is needed not only for the funding itself, but also to make the facility ready for accommodating all the new events in the health events. I think this is most of what is said in our group yesterday, and I will give the chance for also Dr. Omar or Professor Joseph. Also, Professor Joseph was one of the contributors yesterday for
that group. Okay, Umar.
Okay.
You are here. Yes, welcome.
Okay, thank you very much, Dr. Almagila, for the update. You know, I want to give a quick recap. Can you hear me?
Yes, yes, we can hear you very well. Go ahead. You want to show a video as well? Whenever you can, please feel free to show. And just give a bit of background of yourself, if you don't mind. I know that
the video.
Al-Mughira, I just want to, let me just quickly say, Al-Mughira is on the executive board, an economist in the NHI in Sudan, medical doctor, but public health. So I think just everyone give a little introduction so we get to know each other better. So Omar, go ahead. Just a quick introduction and your comments.
Okay, I am Dr. Omar Ibrahim. I hold a PhD in global health with several courses, academics in public health, and also with the intensive experience working across the African continent and Asia and also Pacific. I am particularly interested in how transdisciplinary collaboration addresses health issues, focusing on the SDG 3, the SDG 11 and 17 for now. So,
more quickly, your professional background, just so that we get a sense of that.
Okay, I begin as a community health extension worker. I am also into nursing with BSc nursing science, academic and emergency nursing, postgraduate diploma in public admin, postgraduate diploma in public health, master's in public health, and also a PhD in global health. I also have several online courses that cut across health economics, immunization agenda, health professional, epidemiology, and a lot of others. So
great.
Yeah,
and I think
also
the point is, thanks. The point is really important is that we want to see a diversity of healthcare workers, and so thank you for sharing that background of your professional background.
Yes, and I've also worked in the public sector, in the private sector, in the civil society, and also in the academics. I'm presently in the academics with the research focused on transdisciplinary collaboration, focusing on health systems. So what I'm trying to say is a quick recap of what you've discussed yesterday.
Sorry, Umar, we lost you for now. Umar?
Using Nigeria as a case study.
Sorry, Umar, we lost you for about 10. Yeah, we lost you for 10 seconds. If you don't mind, I don't know when we stopped, when you started, if you just don't mind starting again.
Okay, can you hear me now?
Yeah, just when you started your point. So start with your point.
Yeah, no, I'm trying to make a clear reference to community health work.
Right. Okay.
With Nigeria as a case study, but giving some few examples more. For instance, in Ethiopia, they have made a great advance in the primary healthcare system with a credit to the community health, though not as professional then. And even Rwanda, as of now, they make use of community health extension work to make a great advance in the health system, particularly to primary healthcare. In Nigeria, community health has become recognized since 1986, almost 4 decades today. They have a clear career pathway, beginning from an officer up to the level of permanent secretary. And if you remove community health today in Nigeria, the primary health care will almost go 30% downward. Therefore, to give a manpower credit to the primary health care, to boost the number of the manpower, community need to be recognized, incentivized, and also be given a licensure board like in Nigeria. Like in Nigeria, they giving a formal training, train as a diploma, and also as a HND, and also as a postgraduate, so up to any level. They have a body that licenses them like any other professionals in the medical sector. That is one aspect of the recommendation. And second aspect of the recommendation, we made mention of the contemporary issues of environmental change and public health together as one. For instance, the issue of the climate change. There are issues that really compounded healthcare issues from the environmental causes. For instance, what are the diseases that have a geographical location connection that really excavate the non-communicable and communicable diseases? What are they? And what are the issues of the disasters on the primary health care itself? So therefore, there is need to add environmental change, not particularly climate, but environmental in general as part of the document. Thirdly, I have discovered that throughout yesterday's discussion, emphasis was made solely or mainly on the clinical aspect of the primary health care. Then I'm thinking, how about the preventive aspect, contribution of the primary health care? For example, there is patient teaching for whoever is giving the treatment there. Also, there is also a program of home visits. There are also a program of health education while in primary health care. It is all focusing on prevention nature of the social medicine. I give you another example. The SDG 3 that stipulates health and well-being from 3.1 up to 3.9 is all mainly about preventive, including the universal healthcare coverage. But so as such, preventive health coverage should also be included there. And the fourth recommendation is about the political will. The political will, most of the decision makers came through election, and with most of the law and the bills coming from the House of Assemblies. So we should try to create or recommend a role for those legislatives. You will find them heading primary health care as a subcommittee unit, but almost contributing nothing. So if you try to make a role for them as a recommendation, probably you might be able to win some of the political will. And also another example of a funding pool for the primary health care. For example, in Nigeria, it is agreed that 1% of the total national income, or what do you call it? The national income, they dedicated 1% to the healthcare. Not only the primary health care, but the 1% also be shared among the other stakeholders of the healthcare system. So as such, these are the main things that I could be able to remember. But if Prof. Josana is available, can add more, because he made so much contribution yesterday. So this is just in a summary of what I can remember for now. Also, probably Dr. Oji may be able to send a written document. Probably later I can be contacted.
Wonderful.
That to share. Thank you so much,
That
Prof.
sounds great.
Yeah.
No, that's wonderful.
Thank you,
Thank you, Umar, for sharing your thoughts and Al-Mughira, and we'll wait for those comments from Dr. Oj, from those written remarks from Dr. Oj. So I think the points you raised very important. I think community health workers are actually there. I think when you say they're not included in the document, that's rather odd, because some other people pointed out that we profiled it in the executive summary. It's in the full document and the executive summary, and I mentioned it yesterday. And I think that sometimes there's a question of, are we overemphasizing community health workers when in fact we're trying to look at teamwork? But anyway, that's an important point. Community health workers are definitely an important element. We just need to find ways in which that's perhaps conveyed clearly, and this whole, the whole document structured better so that it does convey things clearer. I think the question that you've raised of environmental health as well, I think yesterday when I shared, the sort of process, I talked about we trying to capture discussions already, which what we've done and incorporate in the document, but that there are other discussions that we would like to entertain. One of them was the question of One Health, which is what you're raising about the environmental health being part of public health with the consideration for climate change. And I think it's an important thread which we are aware of, and we just need to, we don't want to just suck thumb and put something in the document. We want it to be a process, a discussion, and that we then put that into the document. But I think that's an important thing that will surely come in soon into the document. I think the question of the emphasis on clinical versus prevention, it raises a thought to my mind. It's about the structure of the document, that we need to make it, and I think you raise another important point, the political strategy, which I think is important. We have to think about how to make this document speak to different audiences. And sometimes I think that practice model needs to be something very concrete and laid out. Even the process of how, what was raised by Al-Mughira about the how financing and a pathway for the financing. Some of these we need to actually spell out more clearly in the document. So I think that's great points, and I think we'll get certainly comments from the others as we're going along. So I'm just clarifying some issues. I don't want to dig in and speak to anything apart from just saying that some of these are in the document and may come into the document and how that may be. So let's go to the next group. Mughira, you want to comment? Go ahead. And I think we just have one group,
yes,
I think
yes.
the one that I might be able to speak to. Yes, go ahead.
Just honestly, I said that, yes, the group appreciate what is, they appreciate the efforts that are done so far for this document.
Yeah.
But they say that it should be there should be emphasis on the other aspect of health, that because we are talking about health and not about clinical.
Yeah.
So they said that the document is good, but mainly they say that the issues of protection, rehabilitation, preventive part, rehabilitative part, and so on, as part of the definition of health itself, as not clear as a clinical part. Just this is that.
No, I agree. Let's examine that as a part of the way in which we review the document, and it is going to be reviewed. I'm going to share some comments from group, was it 1, I think. So we're only missing Mercy, the group 1. Is that the one? And I'm not sure that I see Ahmed on the call still. And
yeah, Ahmed has not joined the call today.
Right.
So we might have to have you or someone else was in the group give feedback.
Yes. All right. Let me just quickly pick up where I think I might have, and I wasn't writing as writing actively. Let me just see quickly what my thoughts were. Jeff, you were at the meeting, and I'm just trying to think. I don't see notes for myself.
Sorry, we're talking about.
Yesterday's group discussion. I'm just trying to think whether I was writing. I thought I was, but no, I see I wasn't. Do you have some recall of discussion and perhaps can give it? I know that we taped it, so there is some record of it. Perhaps, I think I have some comments. Let me just see if I can pick it up. And I'm not sure whether it was in the broad meeting or not. But anyway, let's just look at it. I think there was from the group 1 as well, very similar ideas about the fact that there is variation in Africa, and that's a big problem. You know, how do we put a document together at an Africa-wide level, taking account of the differences without trying to, to undermine the idea that it has to be localized, anything else. So I think it is something we're going to have to figure out in the document, some of the definitional issues that were raised again, and ways in which we try to get, the document speaking to existent good primary healthcare teamwork, and I think the evidence for change in primary health care. So I think it's an important question. I think that there was a statement about some discussion about community participation, and the big question about understanding facilities. So the community participation was just an important emphasis, much like the community health worker, but I think just getting communities to take ownership around it, that one should not get, I think, in fact, there was an encouragement, came from Ahmed, that we really need the community to be owning it. I think Philemon also raised that importance of communities being engaged in the process. And we were talking about the complexity of community engagement, that, ultimately, how do you actually legislate or guide people, you guide the process of putting in place community engagement without getting tokenism in the way that perhaps current systems work. We also talked about the facilities and the fact that we find that facilities might actually be there where people talked about, well, we've got lots of very nice buildings, but no people. And in fact, the point that was raised, we realized in our document, we've talked a lot about the process, the sort of systems and the human resource issues, but not that we need the sort of enabling facilities. So I think it was a point that was raised, but it brought up, are we being robust enough in terms of what should be happening? But we shouldn't have facilities that are empty, which are not functional, which I think was the point made. I think the other problem was the fact that pharmacy, was not mentioned specifically. And then we talked about how we might be able to improve that question, where there was discussion broadly about, the need to have pharmacy function dealt with. It's an important part of the care given, but how do you work it into this model where we can get decentralized units of care, being able to procure drugs or find ways to access drugs? And we talked a little bit about that difficulty, but that there are solutions around it as well. I think, like was made, this point about political action, I think that we need to have some sort of political strategy that gets the politicians behind it. And I think that, the previous group had suggested sort of engaging with some key actors or framing the document so that key actors, community stakeholders and low-level politicians might feel that this is really supporting their involvement, whilst not undermining the sort of big politicians at the top. And I think that linked in with the question of advocacy and the way in which might do it. And there were some other points raised, I think, about voluntarism and the value of it. But we were saying that there needs to be caution. Ahmed shared projects that they were doing as students, very voluntarily. But we caution that this document can't advocate for voluntarism. We can say that's part of our way of approaching, resource management as a team, but that the stakeholders need to commit to finances, as I think the previous team pointed out, that commitment to primary health care. Jeff, I hope that was useful enough with, just trying to pick off my memory and a few notes I have here. Maybe you can add a few comments in the absence of others. It was a relatively small group with many people moving in and out. So unfortunately, it was not any other people that seemed to be sticking in there. Jeff, any thoughts?
Yeah, I think I was looking through the chat for sort of additional notes and comments. I think you had raised some issues about the importance of research in primary health care. Some comments and concern about the perception and coping with concerns about corruption at the facility level. The importance of community leadership, which I think you mentioned earlier. I think, those are the highlights that I see there.
All right, great. I hope that was useful enough. And if the people join who feel they can, and so it's open. I think we've dealt with the 4 groups. Mercy, I think we've covered everyone. And I think now it's open to you. I would just suggest, please, that you don't unmute, you actually raise your hand if you'd like to comment. And we'd like to get some comments from some of the panelists. Maybe we can start with Dr. Besigye, then Jeff, on just an overview. Sorry, Marie-Claire, you had your hand up earlier. I'm not sure that you would like to speak. Sorry, I did forget that. Yeah, no, thanks, Bayu. I think Bayu's raised in a message to me, but I think that it's actually something we need to raise. The community volunteers are influential in communities. They have an important role to make effective, and then cultural, religious myths, customs. Absolutely. I think that we need to. I think there is a mention in the fuller document about some of these. I think traditional healers we haven't quite raised, but I think this discussion is certainly helping us to frame, to think how we're going to frame that document better. So all these comments are enormously useful. So thank you, Bayu, for sharing those comments. Dan Kibbett, I think, makes the point that the challenge is how do you breach the gap between community, which I think is you're referring to, and Bayu, Dan, feel free to clarify the thing. I'm assuming you're saying between community and the question of secondary care, or is it primary, community to primary and then secondary? That would be useful for you to share that question or to raise it more clearly. And I think the challenge of training more healthcare workers and financing, definitely it's there. And I think we just need to make sure that it's clearer if it's not. Dan, feel free to raise your hand. Let me just allow you to unmute yourself. Sorry. So Dan, if you can add to that comment. Umar would like to respond. Marie-Claire, if you feel like you will need to speak, go ahead. And Dan, we'd really like you to speak. So there, Dan, are you able to clarify that question for us, Dan? Otherwise, let's go to Ibrahim, Umar, and then Ellie. Go ahead.
Okay, thank you very much.
Others who would like to speak, please pick up your hand, and I think that'll be really great so we can manage the conversation.
Yeah.
Go ahead.
I have a 2 brief comment on the issue of the pharmacist raised.
Yeah.
also about the traditional medicine.
Yes.
In the settings, I'm always using Nigeria as a case study because I opportunity to work in the primary care directly. So two things occurs where there are no qualified pharmacies. The community health there were trained based on the basic of pharmacology and the pharmaceutical approaches to be able to watch in and serve to a limited capacity. And also there are a cadre, which is called a pharmacy technicians, which is they spend 3 years in the diploma course to be able to offer a services where a pharmacy is lacking, not as a pharmacist in full, but a way of filling the gap. So this can also make a contribution. Yes, absolutely. Also, and in respect of the traditional medicine, I was opportune to work on a project in PG Island, which we use the title is called Indigenous Knowledge, which incorporate traditional medicine and others. So we need to be careful in talking about this traditional medicine. There are those that really work. Yes, it works with the proof and other things, but the majority of the input is junk. So anyone that's not in tandem with the scientific findings should also be careful with it, because most of them they are there to make money, telling all sorts of things, and then end up killing people in silence. For instance, when they give a highly toxic drugs that is bitter, it went and destroyed livers in silence. You wouldn't know. So we need to be careful in doing that. Although there are practices that are good and confirmed, which goes over time. So this one can be accepted. That's just a quick brief. Thank you so much.
No, thank you very much. I think the point you raise is really important, and I think this is important to include. So thank you for that, Omar. I think that's certainly the discussion on pharmacists. When we had our webinar workshop on the pharmacists, it didn't come up strongly enough. I think, unfortunately, the pharmacy profession was pushing a lot of its own idea that pharmacists are important without addressing this question of task sharing. So thank you for bringing that up. And it's an important point we definitely support. So thank you, Ellie. Go ahead, unmute yourself if you can. And
okay, yes, thank you, Prof.
Yep.
I think you can hear me.
Yes, go ahead.
An interesting point which arose in our group, it was also about local traditional healers who are also trusted by the communities and should be, in our group, we said that they should be part of the primary health care team as community health workers. Now it is to the panel to discuss about that point. Where can we introduce those traditional practitioners?
Definitely. Absolutely.
Okay, thank you. Over to you.
Thank you. I think seeing that you've raised this point and it's becoming, it's an important point. I want to just share a little bit of our experience, and I think it kind of combines the points that both Umar and you raised, Ellie. We in Chawelo, what we do, and I think this is to me a very important model, is we have actually tried to reach out to as many stakeholders. We have community health workers that are paid, trained, and recognized as a very important part of the team that engage in the community and bring that flavor into the practice and we work as a team with home visits, etc. But what we do is we said, let's engage with key stakeholders, and amongst the array from counselor to various other people were traditional healers. And we in fact did exactly that. We said, let's speak to them because and let's engage in a conversation, which is what needs to happen in any primary healthcare team. And it was with that question that Umar raised, that we cannot necessarily incorporate them into the team formally. In fact, we found some of the community health workers were more familiar with traditional healers, and we in fact used them to be helping us to engage. We used them to actually help us to think better. And one of the key tasks we had in engaging with the traditional healers is to say, can we sit together and can we explore ways in which, and I think this is the problem, is we said, we want you to work with us, and we want you to know about TB, about HIV, and can you help us? But when we engaged with them, their biggest problem was they said, well, we send to you, but you don't respect us. In fact, some of the patients we send to you criticize them for having gone to us first. And in fact, you know, if we tell them, don't tell them you came to us. We said, no, that's not how it should be. We want you to refer actively to us, and we need to respect you. And at the end of the day, we will engage with you regularly to figure that conversation out. But we said, we also want you to tell us, what do you do? And what do you think that is important that we are not respecting and understanding, so that they feel a sense of, you know, reciprocity, you know, that we are respecting them as much as we want them to respect us. And I think in that conversation, clearly they can't be necessarily part of the PHC, formal PHC team, but we, and especially because there's a lot of legislative problems, regulatory problems, and, you know, about the traditional healer themselves. And in fact, some of them refuse to be part of that formality, saying that we are not, you know, that's a Western paradigm, even the legislation. So we're not willing to be part of it. So it's a very complex conversation. But I think that we have to go with caution, but also respect. And as any well-trained primary health care team goes, they need to all be in that space of mind, not judging, but actually collaborating. So I think the points you raised are all fabulous. We need to just bring them out much better in the document. Chris Moles, please feel free to unmute yourself. Sorry, let me just make sure I can allow you to unmute yourself. Oh, you can. Good. Go for it, Chris Moles.
Yes, Prof.
Yes,
Thank
good,
you very
good,
much,
good.
Prof. And
Thanks,
congratulations
Mercy. Keep that up.
on having a very good session organized. I'm Dr. Chris Moles from the Center for Health Professions Education at the Northwest University. I'm a nurse by profession, but now a health professions educator by training. I saw a few comments regarding family doctors not being available, and if there could be a good PHC without having family doctors and their curricula or their training.
Yeah.
I also want to put forward, it's my bias, the involvement of the advanced practice nurses that are being trained across the continent, because they play that role that family doctors could play. And in Africa, as we are trying to become more efficient, their training will be less costly compared to family doctors. And so involving them could also help let governments buy into the primary healthcare programs, because they wouldn't spend so much in training them compared to family doctors. Thank you very much, Prof.
Thank you, Chris Moles. And I'm going to let Redwane also speak, because I think he raised the point, is it possible to do good PHC without family doctors? So Redwane, please feel free to speak. Thank you for
Yes.
And quick
Good
introductions, please.
I am a family doctor from Algeria, from Society of General Practice Algeria. And I am very happy to be in this kind of discussion, and very happy to see the draft of PHC. And to go to my question is, how can we have a good PHC if we haven't family doctors with a training of family doctors as it can in the world? In Algeria, we are general practitioner and we haven't a curriculum of family doctors, but we have a big PHC, 2,500 PHC on the area. They do a good job, but could be better if we have a good training. And a curriculum of family doctors who can give us the good work and to be a chef of orchestra of the PHC. I don't know if I have a little English. I don't
know.
No,
thank you very much. Thank you. We understood that perfectly well. So thank you for doing that. And if you needed to speak French, you should try. But thank you. Thank you, Ridwan, for joining us from Algeria. And I mean, you're part of the African conversation. So wonderful. So let me, I don't want to be responding to all. So let me just quickly ask for some of the panelists' responses. Perhaps Dr. Besigye and Dr. Markens, this would be a useful point at which they could maybe let's talk to Dr. Besigye. Dr. Besigye, do you want to share your response to that question as well as any other responses? I think the questions have been raised by Chris Mulls and Ridwane on the question of, family doctors, the need for family doctors, and the question of advanced nurse practitioners, and then the question of training. And just helping people to know where you come from. Just introduce yourself in terms of your profession and your sort of other caps than the AfroPHC.
And it's to declare the possible conflict of interest.
Conflicts,
yes.
Exactly.
Yes, I am Dr. Besigye Innocent. I am a family physician or family doctor, whatever you may want to call it. And I'm from academic family medicine, but also an active practitioner and a clinician. And therefore, I am both in practice and in training. I am from Uganda. I work at Makerere University in Kampala. And again, for those who may not know me, I am the president of the African Forum for Primary Health Care. So I work hand in hand with Shabil. And just to answer the question, whether we can have
and so Prima Famed, just mention that, and then at least the training.
Prima Famed is a network of trainers that are interested, that promote quality primary care and family medicine training. So, and we are also a big network all over the African continent, and with some collaborators from other regions of the world. So, just to answer the question, which is on table, whether you can have quality PHC without a family doctor. And I think my answer, I will start with a yes. And of course, declaring my conflict of interest that I'm from the family doctors fraternity. And what informs my answer is that we must look at the available evidence and the global recommendations. I think we know very well that the World Health Assembly, I think in 2009, and recommended that PHC teams should actually be ready to have enough skills mix that will be required to provide comprehensive primary health care. And they specifically recommended that the family physician should be part of that team to provide leadership and governance of the team and also mentorship. So I think where the ideal situation would be to have a family doctor being a part of the team. But we are also aware that in very many countries, family doctors are actually not there for some of the reasons which the members have raised. The training is costly. And also in some countries, there are no training opportunities. We are also aware of that. And because of that, then we can now go to the second option, which is having other healthcare professionals forming the team without the family doctor. It still works, but I think it might not deliver the quality primary care services that may be required. And of course, over time, I may say that the training of family physicians or family doctors on the African continent is a relatively new kid on the block, that we have had programs starting in some countries. A good number of countries have training programs, but they are still really not enough to really cover the required need. So I think that would be would be my brief answers to the two questions being brought on board. And I would request Professor Shabil that I have seen Prof. Ian Cooper is online, and he has been a long serving, a long time trainer of family doctors. Probably he should also give us briefly some insight on what his thoughts are as far as those questions are concerned. I just also wanted to make
I think he's left.
Comment. He has left.
Yeah, he's left.
Okay.
Sorry.
Yeah, again on the document, so that I just go off once. I think we all agree that this is an important document, which we must keep as a living document that must evolve according to the current to the circumstances and the new evidence that is evolving, and the new guidelines and other documentation that will be put in place concerning the PHC. And for me personally, I believe, and I think we have all the global evidence looking at the Declaration of Alma Ata, Declaration of Astana, and all of the accompanying documents like the World Health Report of 2008, that the political will, both nationally and globally, for PHC is actually there. I think what we need now to start looking at is how do we leverage on that political will to political action? Because I think it is the political action which is missing, and I think we should try to also have that component into that document, probably to guide the people who are going to be using the document. How can we advocate for advancement of political will to political action? And again, the other thing I've been thinking about since yesterday when we were discussing is how have we aligned this document to the current conversations on the PHC table. For example, you know that after the Declaration of Astana, there was the vision for PHC for the 21st century, and important of all, the operational framework. For example, how have we aligned this document so that the people who are going to be using it can actually use it alongside that operational framework? I think some of you may be aware of the 14 levers, both the core strategic levers, which form the foundation for a well-functioning and strong primary health care system, and then the other 10 levers which are operational, those which will make the PHC take off and work. But I am just wondering, we need to really see how this document, how the two conversations can actually align, that we have this document being able to fit within the PHC operational framework, so that when the people are using it, they can say, yes, globally, this is what is recommended, but also us on the African continent, this is how we can fit within that, within the global recommendations of PHC implementation. So thank you very much. Those are my brief comments. Over to you again, Professor Shabir.
No, thank you. Thank you. Very useful comments. And I think the add-ons on the question of alignment and political will, very useful points. Jeff, do you want to, perhaps I would, I don't want to throw you into the deep end to speak to this, Jeff. So let me just respond as well to that question about family doctors and advanced nurse practitioners. I think that that the question of, well, firstly, family doctors, they're not one animal. In Africa, across most of Africa, family physicians are postgraduate trained, usually with an emphasis on hospitalist care. So family physicians are a scarce resource. And in fact, the family medicine, the family physician community has realized this is not sustainable. It's going to be very marginal in terms of being able to contribute to the broader primary health care setup in Africa. And there's an increasing conversation about training the doctor who's come out of medical school with undergraduate training, the general practitioner, the medical officer, training them to actually fit better into or support better universal coverage primary health care with a whole bundle of things. And we in AfroPHC are busy with that kind of diploma, online, distance-based, very much supportive of scale. So that particular animal is not just, that diploma is not just for, when we look at it, is not just for a doctor, a medical doctor with no postgraduate training. It's also for an advanced nurse practitioner who has just had clinical training, or a clinical officer, just clinical training. We want to take them higher, skill them up again. Sometimes in the practice, they tend to drop their skills, skill them up again, but bring them into the context of better primary health care service, as well as how to structure and organize under the circumstances which we are talking about. And I think the point you make is that we should be careful, because that's the conversation we want to avoid, as one cadre will solve all. We are very clear, but that is not going to be able to happen. But we do need to understand that you can't say, oh, well, we don't have advanced practitioners, so let's just train, professional nurses in a few weeks and they'll do better. They'll do the same. And, if you take them and structure them into let's say, nice research projects, provide them all the support you can easily show with the algorithmic training that they have that they can produce good quality. We know that, because even community health workers can actually be delivering really quality care if one does that. But the problem is that you have to be careful about the problem of actual implementation. When implemented in the real world, what happens is that people are thrown into the deep end without the support and supervision that they have. And so we are saying in AfroPHC, let's find a way in which we bring the skills mix from top to bottom, but look at the question of HR shortages, but also find a way to blend that in country and as a principle across the continent, that there should be a blending of how that mix happens with a good skills mix, but allocated to a population, not just plonked in a facility and left to fight for themselves with this, unnameless numbers of patients. And I think that's the real paradigm shift. So in that space, we will find a lot more opportunity to get the shortages addressed by improving the quality. And we have to find evidence for that, and we have to make up that, because there is evidence already to say that we can deliver high quality. I do that where I've worked in Shawelo, and we've been able to do that with the team mix, including community health workers, and doing it at far less cost. But it's the skills mix that matters. And so cost is relative. And one needs to ask the question, how do we go about this? I see a lot of people have fallen off. I was hoping that they would still be there. So Victor, I had others, please do not drop off. I hope you're going to still continue the conversation. And we'll still use the chat to actually pick up the conversation as well. So Victor, I'm hoping you can unmute yourself. Please go ahead and raise your question. Razia, please. That'll be great.
Hello.
Yes. Go ahead, Victor.
Thank you so much. I'm Victor from Kenya, and my background is basically in economics, banking, and finance, and a bit of community development. That is academic wise, and also I do a bit of monetary evaluation. And for the last 11 years, I've been implementing projects within the community, that is development project, with focus to health promotion policy and primary healthcare financing. We look at the budget allocations and tracking on health financing, that is both in commodities and also services. So basically, my county, that is Kisumu, one of the 47 counties in Kenya, is launching the family health operation plan in the next 2 days, or these 3 days, on 23rd. And these are tools that we took part in the processing from the onset. And just today, I received an invitation from the health department that they will be launching officially. But I want to give a scenario, because we understood the fact that we don't have family physicians majority. We have, we roughly in Kisumu currently, we only have around 2. So what did we do to make sure that this one worked for us when we are developing this operation plan? One thing is that we acknowledge that we have a few. And so we came up with a family health team at the sub-county levels. And you realize that now we've ensured that we have the physician, the family health doctors being part of the primary healthcare team. And the operation plan is structured in a way that you realize that they are offering supportive, like basically said, they are offering supportive role in terms of governance and also helping just the system to work and taking consideration that all these other people are not family health doctors. And these have been trickled down, and basically they are situated in level 4 and level 3. They are situated in level 4 and level 3. And so they coordinate all other level 2 facilities, because that is where the primary healthcare services are situated mostly, because level 3 and level 2. And so they are at that level just to offer the governance, to offer the guidance and so on. And another thing that we've worked on is mainstreaming referral system, a lean referral system that will ensure that that coordination is enhanced. Because when you don't have a number of family doctors, then you will have to require to strengthen the referral system so that they can operate in within that channel to make sure that services are offered amicably. And this one also will solve the cases of referrals, because there is no need of, we believe that there's no need of implementing family health if you are still going to refer 100%.
That's right.
Yes. So if you are still going to do referral 100%, that is not family health. That's family health is not working in that case. So considering that, we have managed to come up with that structure. And this has been a journey of civil society organization, where personally is my strength, because I run and I've been running this institution from 2012 to date as the director. And we've been engaging in developing these policies just to make sure that sustainability is realized in the long run. So that is the case that I wanted to share. And I want to agree with Besige that even though I'm not in the practicing health practitioner, but I can say that this is something very important. What is more important is that let's have it in the system so that it be sustainable. Because like you said, we don't need just to talk about the goodwill. We need the action. And when a living document is put in place, like right now, we are sure, even though we are going to the election, this document will have been signed by 23rd next week. And so any government that's come on board will find a living tool to implement it.
Wonderful.
Yeah.
Wonderful. Well, Victor, thank you for sharing that. And I think really we are going to have to go on a very, very deliberate exercise to get more examples. I think you're sharing, and we'd love to hear more about exactly what you planned. I think the principles are very much aligned, it seems, with what we're talking about. And I think that's really what we need to hear more of, is examples of this kind of flexible team-based approaches that are person-centered, that have that principle and are not reductionist in the way in which currently we all as health providers are being forced to accept. I think that the question of, you know, raising the in response to what Krismal says, you know, there is a lot of waste happening at the moment in public service that is very reductionist. And also that's not a whole of government approach like we've heard from WHO that we expect, where government is actually looking at all the resources, public and private, and then sitting and saying, how do we structure systems to in fact pull all of those people together and find ways in which you can drive a overall health system that includes them all, and what is the kind of configurations of teams. So we want to get some lateral thinking. And I think that what Victoria raised is really important, is this question that primary care, yes, you know, we want to define it, but it doesn't operate in a vacuum. And it's one of the points that I think earlier somebody raised is people come to the primary care service, and if they don't find what they need, they will find a way to get to that hospital and to that extra service elsewhere. And I think that really is what this project Victone has put in place, is about understanding that dynamic, that skills are needed lower, but it needs to be matched against resources. And I think that's really wonderful to hear about that, Victor. And so really appreciate you sharing that. We are going to have to find ways to get you all to share examples. So let's turn to the next Razia. And sorry, if I would just quickly respond to also what Innocent said, the alignment to docs on the primary healthcare table, we've done it, but I think Innocent raises an important question of the operation framework of the WHO with the 14 levers. That might itself be a step to then leverage political will, but we need to think about that more carefully. But one of the things that we have applied for funding, we'll have to see the outcomes of it, but we've applied for funding, and the funding has been to try and look at refining this document precisely on that question. How can we look at the question of taking PHCPI's core indicators, the vital signs, and actually look at how we might incorporate it into our document to look at outcome measures? How can we say we would want to be measured against this, and let's look at how we reconcile with that, as well as the WHO's PHC measurement framework and indicators. So we've applied for funding to both look at that kind of thing, as well as the literature, I think, that people are talking to, that there's more evidence out there, we need to refine it, as well as examples. And we also incorporated into that application a way we can reach out more, get to engage more with many more stakeholders in Africa, as we're doing, but perhaps a bit better. And we hope that we can actually use that funding for it. So let's hope and keep fingers crossed and pray for it. So Razia, over to you. Thank you for keeping on. I know we've taken long to respond. Go ahead, Razia.
That's okay. Thanks, Prof. I just don't know if the ship has sailed. But anyway, people have been talking about the quality of care and the quality of PHC care. Okay, most recently now you've been talking about without doctors, but initially you also spoke about without pharmacists, and pharmacists being very proprietary about their role, and thinking that these things can't operate without them. And we know that even in our own situation in our country, primary healthcare facilities have been running without a pharmacist stationed at the PHC facility, and that's been the way it's been done for years. But just for me, what I wanted to say is that, the model of using roving teams, where you have a supervisory capacity, where you can actually work with the primary healthcare facilities, is one of the things you can consider. And then also looking at, when we think of primary healthcare and we think of the tools that we already have, you just spoke about the WHO and the core indicators that we can use. We can also use those to measure national drug use at primary healthcare facility. So you can actually downscale, if you want to call it, use mid-level workers or even train community health workers to look at the things that are very important in terms of delivering, let me speak of pharmaceutical services, being a pharmacist, and things that you would look at at that level of PHC, where we already have standard treatment guidelines. We have few medicines that have a strong evidence base that we've been using for many years in primary healthcare. So it's easy to train people on what to look for, what to be wary of in patients. So looking at, in the communities, community health workers helping with things like medication adherence, for example, and then at the facilities itself, we want cost containment. So looking at things like expired medicines, how do we save costs? How do we diminish waste in terms of pharmaceutical services? Looking at continuity of supply, those are the things that are important. And those are not really core functions of a pharmacist as such. Those can be taught to other cadres of healthcare workers. And looking at, stock control, for example, things that matter at a primary healthcare level, that when a patient gets there, that the medication is available. So yeah, I just wanted to speak to that, that we do have tools and we shouldn't forget those tools. And we shouldn't forget that it's easy to pick out a flailing community health center, for example, by using those core indicators and by measuring those core indicators, maybe, if not systematically, then occasionally, at least. Yeah.
No, I agree completely. And Razia, maybe you didn't quite understand the point I made, which is that there is no way doctors can say only doctors can deliver on primary health care. Like pharmacists shouldn't be able to say, well, we are the only ones that can do X, Y, Z. And I think, like pharmacists, example, are beginning to provide some simple clinical care. They being trained, and there's obviously a capacity, competence that being built up. So in my mind, and I think in this setting, we have to see the value of every health professional. The question is, we can't say we're the only ones. And I think that pharmacists, together with that pharmacy fraternity of technicians, etc., and we have to figure that out across the continent, should be able to start working together and asking the question, well, actually, to really get the best quality of care, but the best use of human resource in this country, what would be the pharmacist to technician to other people that could do certain task sharing? How would we compose that team to a particular population? And this is a conversation we must do, because in my view, I would not be happy to not have a pharmacist having an impact on a population that I am caring for. It may not be that it's, that's one pharmacist to 10,000, but at least if we have 5 doctors as an example to, in working in 10,000, 50,000, might say, well, I do need that competency there. Even if I'm working 10,000, I want a pharmacist to be able to supervise the pharmacy assistant that I have in my practice or in my clinic. And that's what we need to get to say, no, there's no need for a pharmacist is rubbish, because that's a discipline that's very important. We can't have it to everybody to the same way that we perhaps done in other parts of the world. But we have to also look in our country and say the public-private divide is an artificial one. Put them all together. Now let's ask, how can we divide them up properly and now put a system that actually brings them all into one space to care for the whole population? And that can be done. And we are having economists. I mean, Victor, I'm sure, would tell of what's going on with UHC systems, and it can work. So we need to be able to press to do that work. That's a lot of work, but we need to be committed to the principles. So thank you very much. I think, Jeff, do you want to respond to what the point you just brought here? And then we can go to Mercy, I think, who's got a question. There's a trajectory on how they trained and used. Jeff, I think some global perspectives on how this issue is dealt with. Feel free to unmute.
Yeah, I mean, I think, I put some comments in the chat in general about the importance of, I think, PHC team training and comprehensive frontline service delivery and primary care functions in general is really important across the whole team. I think the second thing is, to your point about the kinds of providers that, can and are available to provide services and making sure they get training. I think one key anchor for the PHC team is somebody that's able to provide diagnosis and management of undifferentiated and atypical presentations of the front lines of care, because, unlike when folks go to the hospital and they self-select to go to a pulmonologist or a cardiologist or whatever, that makes diagnosis quite a bit easier. Whereas, for folks who are on the front lines, they're having to deal with a wide range of things. And particularly if they're well integrated community health workers, those community health workers should be very skilled at managing the kind of routine problems they might run across. But what you would expect is that when they find something atypical, then they move it up the ladder to somebody else to help with. And having somebody who really is skilled and available to do that's important. And so I think if you're training medical officers or advanced practitioners or even nurses to do that work, that's one important lens to keep in mind as you're doing that training. And then in terms of the family doctor piece, you mentioned, I think very importantly, the issue of how many family doctors in Africa at the moment are working in hospitals and sort of hospital-based settings, and that's not really a sustainable model. And one of the things that I've seen sort of as a trajectory, and I've seen this most acutely in my work in Southeast Asia, has been how health systems sort of mature and how family doctors move along with that. So when I think of Laos, for instance, so that's a place that tends to be very low resourced in terms of human resources. And so it's very similar to Africa in that there may only be 1 or 2 doctors in an entire hospital. And so the focus among the sort of primary care functions, those 5 C's we think about, tends to really be on comprehensiveness, that they need to be able to deliver a huge range of services, and basically be able to provide those end-line services at that district hospital for anybody who comes in. Whereas like in Vietnam, where they've built out 11,000 community health centers, it's a very different job for a family doctor in that place, right? The focus now shifts to continuity is really the key. Patient-centeredness is really the key, and being able to kind of manage sort of a range of less acute problems at the front line of care. And what I've also seen happen is that at some point you kind of do that training of those hospital folks, and then you start training more doctors than you have spots available for. And one of the challenges I've seen is health systems then making that transition is they've started to finally scale up the number of providers that are available to start saying, okay, now we're going to start paying to have those people out in the community at the front lines, and not saying, okay, there's no value to that provider anymore. Yeah. That's probably not true. But there is a transformation in the health system that needs to happen at that point where you're starting to really begin to fill in those frontline services with, broader and more comprehensive PHC teams.
Absolutely. I think it's a very dynamic process, and it's a path, I think a trajectory, like you point out. And I think we need to see how do we structure the principles around that trajectory without getting stuck in sort of concretes that become limiting. So thank you very much. I'll go to Mercy, and then I think there are comments from Joseph Anna. I'd really appreciate, Joseph, if you can speak to them. And thank you very much to Prismals for that. Go ahead, Mercy. Good.
Thank you, Prof. Shabir. Short introduction. Mercy Wanjala, I'm a family physician from Kenya and a member of the AfroPHC executive coordinating team, coordinating the policy workshops. So I'm just going to speak to a few things that I heard from the groups while I was moving around yesterday. One was the concern that the document will not speak to the realities and the context of what is happening in Africa. So one thing is just thinking about it as policy documents and guidelines as a recipe. Like we write down something that ought to be the way it should be. So if you want certain results, you follow a certain process, you invest in certain resources, and then you get certain results that you're looking for. So depending on how you will implement or you will use that recipe, you will either get the product that you want or the one that you don't want. And this alluding to what I had one of the participants in the group actually saying, which is quite true, is that we get a lot of policy documents, the Almata, the Standard Declaration, all that. We sign on to them as a country, as a nation, as a continent. But then when it comes to implementation on the ground, we don't do it. So then what will be the value of developing another? That is just a comment I'm bringing that I heard from one of the groups yesterday. So I think it comes down to that it will come down to a lot of what we are willing to do, right? And even as the people on the ground, because I believe a lot of people who joined the policy workshops, who joined this conference, are actually the people on the ground who will do the implementation. And I believe that the people on the ground have a voice. So then how will you use that voice? Because sticking your head in the sand doesn't make a problem go away. Just saying, oh, I'll just go into work. So part of why you're speaking up here is also part of how we will go and speak up as a person on the ground, as a person who experiences it on a daily basis, the patients coming in, what they do not have, the gaps that are existing. A policymaker may not know that, but you know that. So then are you going to do something and speak up about it? Are you going to try and speak up about the gaps that you see objectively and also fact checking the things on the ground? Because I've had a lot of say about how we lack resources, how there's shortage. But then again, I always say we need to fact check those things, because I give an example of Kenya. You'll say there's a shortage of specialists, but you find 100+ surgeons in a city fighting for work within the private sector. So is it really a shortage or a lack of resources, or is it really a misdistribution or mismanagement of the existing resources? Because when you fact check, Africa is one of the richest continents in terms of natural resources, human capital, you name it. So then I don't think us saying it's a lack of resources would be correct if you fact check it. Then it's a matter of where are the resources and how can we best use them, not only as current policymakers or future policymakers, but also as the people on the ground. What resource is available, what is not, and how do we use it? So even as we are going into this document, talking about how we can change the primary healthcare system, let us think also about us on the ground. What do we have? What do we not have? And what do we need? And just to emphasize what has already been said and what is in the chat, the whole team-based issue. The problem is this is a new concept to us in Africa, but it's not a new concept elsewhere. I had the privilege of doing my family medicine training in Cuba, and there it's all about teams. Nobody works by themselves. Nobody studies by themselves. And what the doctor, the nurse, everyone is studying, it's the same thing. What they study about the primary healthcare system is exactly the same. You ask a doctor, you ask a nurse, you ask a statistician about the primary healthcare system, they'll tell you the same thing. So this is a new concept to us, but it's not a new concept that's being developed today. Because for instance, for them, they've been doing it for 40 good years. They have developed a primary healthcare system that works. And in terms of resources and human capital, they don't have that much. It's a country of 11 million people.
Yeah.
So you'd actually see that in terms of resources, they may even have less. So this is something that can be done, should be done, and we should make sure we are part of the process and giving our voices just as we are doing it today, so that we are the people who are telling the story because we have experienced the story, and not someone else writing a different story and then telling it differently and then making us try to live that story, and it is not the truth on the ground. Right. So I think, yeah, those are just my thoughts around that. So thank you.
Absolutely. I think those are really important things. I think the point you raise, you know, about the context of reality, and I think that context of reality is just shortages. And I think you point that out as a limiting belief, that we are not looking at the bigger picture. And so in some ways, part of our the political action is going to have to start with our members, AfroPHC members, to empower them and educate them on how, with lateral thinking, with thinking slightly differently, we could in fact see lots of the opportunity available, and then get our policymakers, starting at where we are at the front line, in our work context, the local politicians, in the places we can influence, that we can in fact empower them to think, well, there are solutions. The government, this needs to think differently and to go about it differently, and there is a way in which it can be done. So I think that's really good. We should be, and I think that, we need to get the principles right. And one of the key principles is this, that we need to have respect for that primary health care team, how it's conceived, how it's put together. And I think there's some useful comments. So let me turn to Joseph, Anna, and perhaps Jeff can also respond to that, in the conversation. And I think, like Umar says in the chat, it's a steady, slow process. And we are going to have to work with this slowly as we're going along. So Jeff, Joseph, do you want to add your thoughts? I'm just see if you can unmute yourself. Go ahead. There you are. You can now unmute yourself. Joseph, any thoughts? Just share that question.
Thank you, Shabe. I didn't quite hear fully what question she was posing. If you could just
Mercy was just talking about, the question of, what she did is she found many of the groups speaking to the fact that the document doesn't speak to the context of reality, but she made the point that we kind of face in the public service shortages, and we look at this document and we see it as, it's, that's not reality. But the problem is that we need to get people to think differently, that in fact within our settings, in the public and the private, which the government needs to take account for and actually build systems that brings those two together, which is really what we've encouraged in terms of strategic purchasing in our discussion document. So it's about thinking differently, bringing the public-private together and seeing the total opportunity, and then saying what systems will bring them all together. And I think, like we say, like I said, we need to educate and empower our members to think differently, and that they can then get the policymakers to shift their thinking as well. So I think you raised the question, you were having a conversation in the chat group about I think your point was about working together, and that, leadership is different. And I think I'll respond to it, but how do you get people thinking about teams without thinking who's in charge? That's a big problem.
Yeah,
and appreciating the roles people serve.
Yes, I was going to start by saying that what Matthew was saying rings a bell, because that's the point I was trying to raise yesterday in my very brief comment.
Yeah. If you wish to share some of the slides, feel free.
Okay.
You can do it later in a few moments, so don't rush. We can do it just now. Okay. You can just pick up your hand. We'll take it.
The point I was trying to make was that any policy document, any guideline needs to speak to the particular context where you want to promote it or where you want to adapt it. You want acceptance. If we spend all the time and effort as we're doing now rightly to produce a document, it's important that as we begin to scale it up through the continent, that it is acceptable from one country to the other. And so the point is that there's not one whole Africa PHC as we speak.
Sure.
There are different PHCs in Africa at the moment. I believe that what we hope this document will do will begin to bring these various PHCs together. So at some point, we'll have what seems like a uniform PHC that will speak to the international documents that we've been referring to. Whether it's AMATA, whether it's Astana, whether it's WHO, there seems to be a consensus and agreement of what primary healthcare should be. Promotive, prevention, curative, rehabilitative, and so on. So it's a question of how do we achieve all of that in one particular country. I'll give you an example. You take Nigeria, for instance. The concept of community health worker in Nigeria has been thought about very deeply, such that the community health workers in PHC in Nigeria are called community health practitioners. And they include the junior community health extension workers, community health extension workers, and community health officers. They have a training curriculum. They are trained in the colleges of health technology, and the CHOs, the community health officers, are also trained in faculties of community medicine in the university. Then they have, when they finish, they have a career path. They are given pensionable appointments, and so that they are rewarded for their contribution to primary health care. This is Nigeria's answer in some way to the huge human resource shortages that we face in the country. But I also know that every other country has human resource shortage. But this is Nigeria's own experience. So any document that we produce in AfroPHC that doesn't recognize that will have some difficulty in being in finding acceptability in the country. Then when you go to healthcare, health financing, in 2014, Nigeria enacted a National Health Act. In the National Health Act, it is now mandatory on the federal government that every year, at least 1% of the consolidated revenue of the federation, the whole money that Nigeria makes, 1% is devoted to primary health care. And that is quite apart from the ministerial allocation to healthcare. This is just specific for primary health care. And that is to enable the primary health care in the future to be able to respond to that promotive, preventive, curative, and rehabilitative functions that AMATA, Astana, and the rest of the world have dictated for primary health care. So I'm saying that the document, when we produce it, I'm sure other countries have similar ways they've been trying to provide accessible, affordable, and functional primary health care. Let me leave Nigeria. Rwanda, for instance, we all...
Sorry, Joseph, we're losing you.
All have heard about the Abuja Declaration 2001, Rwanda of the African Union, that each African country should allocate at least 15% of its annual budget to health. So that's another good example. And Rwanda is a good example for performance-based financing. It was piloted, Nigeria took it and piloted it in an entry program. So our document needs to recognize all these practices in different countries and see how we can bring them together to gel, so that when the document begins to be rolled out, it will find acceptability and a buy-in in the various countries. That's this point I was making. Now, about team working, again, our experience is that because there's huge shortage of human resource in health, especially in the clinical sector, you don't have enough doctors to man every primary health center. You don't have enough nurses or midwives to do that in most African countries.
Sorry, Joseph, we seem to have lost you. Sorry, Joseph.
Why the cadre of community health practitioners was created. I don't know why it's lost me.
Yeah, I think you were just talking about HR. Yeah.
Yeah, the teamwork.
Teamwork, yes, yes. Go ahead.
Yeah. In fact, in my experience, what we try and do in the primary healthcare in the centers where we work in Nigeria is to try and replicate what happens in the hospital sector, where it's a teamwork. The leader of the team happens to be a medical doctor, simply because in the composition of that team, he or she is the most trained and the most qualified when you take indicators like entry into your profession and so on, entry into universities and so on. So it's but the leader still has to recognize the contribution made by every member of the team, from the gate man to the mortuary attendant, to the chief executive, to everybody, the nurse, the midwife, everybody, the porter, the cleaner, everybody makes a contribution if we're going to deliver a patient or a person-centered care. And so long as the leader understands that, it could be anybody, but as we stand today, it happens to be the medical doctor because he's the most trained and the most qualified in the team. And in my experience, I actually don't have a problem with that. 3 years ago, I was given a national award by the Nigerian Association of Community Health Practitioners. I'm a doctor, but they give me that award. So it's how it works in practice that really should matter.
Can I ask quickly, Joseph, while you're on the call right now, while you are unmuted, when you say that you recognize the context and the document needs to recognize the context, are you saying that that the document needs to mention the Nigerian community health practitioner to be acceptable in Nigeria? Because that's going to be a problem. So I would like to ask you, what do you see as a gaps in the document? In other words, that it doesn't say that needs to be said that will help it to be acceptable across Africa. Because what we need to do is we've got to be careful, because if you say that, then there's somebody in Senegal who's going to say, but you don't use the French name for this particular community health worker or health practitioner of any sort. And we're going to get ourselves locked into this contextualizing problem where we say, maybe an appendix will help us to say, listen, we are talking of all these different people, but that the document itself, main document,
let me answer your question.
Everybody.
Yes,
go ahead. Yeah, go ahead.
Yeah, what I think we would probably aim to do, if it's agreeable, is that we could make references. The document there are thematic areas in the document. So when we are talking about, say, human resources for health for PHC, if we have examples in Africa where things are happening, we cite those examples. They could be in the reference or in the appendix, but it's cited for people to be aware of it. And then when we're talking about health financing for PHC, we do the same. When we are talking about engaging the private sector for PHC, if there are examples somewhere in Africa where it's happening, we mention it. I tell you why I feel the way I feel. It's because if we don't give African examples in the field, when we begin to disseminate the document, we are going to be asked those questions. If I give example of the NHS, National Health System in UK, for instance, I'm going to be asked, come on, what about this thing we're doing in Abuja? What are you doing about it? Haven't you heard about it? Or the person from Ghana will say to me, oh, we're doing some things in this area. So I think the document should, as far as possible, where there are examples within Africa, use that example so that every country can be aware of what's happening, and you can take it and localize it. You don't have to take it hook, line, and sinker. You just take the idea and localize it to your own context. But it is, because it's coming from within Africa, it will be more acceptable. That's the point I'm making.
No, that's fine. I think that's clearer. So I think we're just going to have to figure out how to manage the size and the nature of the document. But I think there's, in a sense, a reasonable consensus around the ideas that are there. So I think, yes, community health practitioners, the community health worker gets quite a big mention. I think the question of financing as well is there. Perhaps we need to spell it out, like Jeff has pointed out, maybe a more clearer 1% PHC that is more achievable and maybe becomes headline. I think there's a response, to the question of the leadership issue that you raised, Joseph. And I see Mercy's responded to it. So let me ask her to speak to that question, because I tend to agree with her that, I've written an editorial on leadership in clinical governance, and it's referenced in there that really we need to have a different way to think about leadership. That it is not necessarily just a role, and it's about teamwork and the ability to deal with it. So let me to perhaps speak to that. Mercy, go ahead.
Thank you, Prof. Shabir.
That point is important.
Yeah, I think the question of leadership will always come up because it's, I'll quote, what's his name? John Maxwell, who said, everything rises and falls on leadership. So it'll always come up everywhere in every conversation where you go. And the problem is when you have a flawed concept of leadership, then you're going to have a problem with it and you're not going to be able to do anything. And I believe in the African context, we've had leadership as position. Who is the most senior, who's the oldest, who's been here longest, and then
who's the most qualified in a particularly narrow way,
the most highly trained, who has the most papers, like in terms of degrees, PhDs, etc. And then we decide that that person should lead a group or lead a team. And I believe that's a flawed concept, because when you go even deeper, you realize there are certain qualities of a leader or leadership that need to be in place for someone to successfully lead a team. Like, I agree with what Joseph mentioned and what also Elias mentioned, the multidisciplinary approach, appreciating every member as a contributing member to the team. And that cannot happen as long as leadership is viewed as position and seniority. We need to move away from that and realize it's a role. When you are in that role, your role is to bring people together. Your role is, for example, to coordinate. Your role is to bring out the best in the rest of the team. It doesn't mean that you're better, you're higher, and all those things that come with that concept of position. So we need to understand leadership as more of a role. What do you do in that role than more of a position, and also appreciate new concepts such as shared leadership, whereby everyone in the team is a leader, leading in something, doing something, and contributing, and also distributive leadership, where everything doesn't depend on you. You have a team, and the team supports you. Yeah.
No, thank you, Mercy. And I just want to respond. I think that does not contradict the point that Joseph, you made, because I think in that article I wrote, we stress this is the nature of leadership, but clinical governance and the hierarchy of clinical governance is the point you're raising, actually, that we need to have a way in which clinical issues, there is a way in which the doctor who's trained is able to guide the nurse, and in which the nurse who's trained is able to guide a junior nurse or a community health worker, because from the clinical point of view, there might be a need to ensure that there is that accountability. Because the problem is that if that is not there, then the quality of care, especially in the clinical domain, might be wanting and the system may crumble as a result. But we need to appreciate that there's expertise in also other parts like management. There's a skill. A doctor may not have that skill. He is important to manage the clinical governance and referrals, but he may not be the best person to, in fact, run the facility because he doesn't have the management capabilities. He's not well trained in that, although we want them to be trained as that, and everybody be trained in that. Or the community health worker who is very expert in relating to stakeholders. He might be the expert because of lots of things that isn't easy with training. So I think that is, again, ways in which we have to think about expertise in the leadership space, but also the importance of clinical governance and clinical accountability, because our system of primary care, healthcare generally, is premised largely on the sort of allopathic model of care in a clinical space, and costs incurred at hospital come out of a consequence of poor clinical care at a lower level that then translates into higher level care. And I just want to say that, higher level care is very invested in better quality primary health care. And you do need clinicians, clinical accountability to ensure that that what happens is appropriate, like the pharmacists. Sometimes doctors don't appreciate the way in which they're doling out drugs, the fact that drugs are inappropriate, and the polypharmacy or the cost of drugs. And they need to be able to direct that doctor, and that pharmacist needs to be respected for this expertise that they bring to the team and its impact on costs higher up. So I think and I think even the question of how the prevention to the rehabilitation happens. All that expertise needs to come to bear, and it's a mix of team members that will be able to bring that together. So Bayu's raised some issues really wonderfully. Let's take Bridget and then Bayu. Bridget, go ahead. Thank you for the comments. I think we'll go until the hands stop and then try and wrap up with comments from our panel. So Bridget, go ahead. I think you can unmute. So let me just help you. You should be able to. Good. And then
Thank you.
Yes, go ahead.
Thank you very much, Doc. And very, very happy to be part of this team. Like I mentioned to colleagues yesterday, I am a Kenyan working in the external humanitarian space, currently based in Yemen. And I would like to really overemphasize, I joined this of interest because I've worked indirectly with several forums, both at continental and regional and global levels. The bit of leadership is something we would not want to overlook. Like I think one of us has said that it's not whether it is the doctor, the nurse, or whoever becomes the leader, is the principles of us in this policy document, because the whole thing is the advocacy that this policy document brings. I'm not sure that AfroPHC wants to bring itself to a level where we want to start saying the details of who is the traditional Badatedas, with the traditional healer, with the family doctor, because like the doctors here from Kenya will bear me witness, family doctor is not a common term, for example, used in the country where I come from. But you will find things like a general physician, you'll find things like every common person will say doctor, and everybody becomes a doctor, even a community health worker back home. So I think in our policy document, what I would like to kindly advocate for is very clear statement on, for example, when we get to the level of leadership, let's talk about the senior most, whoever will be the senior most based on that country's perspective of which level is PhD, then that person takes leadership. It is very complicated over even where I currently work to talk about a leader, to talk about a doctor, to talk about a nurse, to talk about whoever, because the understanding, the implication and the outcome and the overall output is always, I think we are obsessed with positions, we are obsessed with titles, and most of us will want to align ourselves to this. So within the document, as you may have noted in my comment, and yesterday I also said that we look at being very clear on a particular line so that we are not putting any gray areas. And then people will go around blaming the teams for, oh, the policy documents this and this. So we just need to kind of tweak to make sure we are being very clear and non-vague, at the same time being accommodative of various steps and what they pledge in terms of who becomes the leader, who becomes the member. Because one of the main things you got not to overlook is the role of the lowest level person, even the gate man, to lock out somebody coming to seek health services, for example. If they understand what is primary health care, then they will actually end up being promoters rather than blocks for access to service. And then finally, what we'll be looking at is what exactly do we want to achieve at the end of this policy draft that we're working on. As we get, I'm seeing us in this discussion getting into the operationalization of the policy rather than the key things we want to capture, then we need to go back to ourselves and talk about the uniqueness of each country, which I like the comment you made, Prof, that, you know, like you put about Nigeria, Senegal will come and say, no, this and this. You put about Uganda, Kenya will come in and say something different. And just to summarize, thank it's really a very good document, very well thought of. And I think at the end of it, a bit of editing, retweaking would make it a most profitable document. And some of us are happy to be part of the process. Thank you.
No, thank you very much. And I think that, you know, we have to steer away from, you know, the sort of professional turf issues and look at ways in which we can encourage, you know, the principles better. So thank you for that. I think sorry, we had asked, was it, are you able to speak? I know you left us. I think he's do you perhaps you want to share some of these comments? I think he's left us. Jeff, do you want to share some of his comments and so that we can sort of reflect on them, and then I think we can just go to any other people who have got questions, and I just pick up some of the comments that Umar has just put as well. Anything you'd like to add from there, Jeff, from that private conversation?
Yeah, I think just the question was around the balance between sort of a family medicine approach and sort of a more frontline community-based community health worker approach, and whether that might not be the more sustainable and efficient model to apply.
The family medicine approach versus a community health kind of approach.
Correct.
Yeah. And is the community health worker approach he sees as more sustainable?
Yes.
Okay. It's probably comes from the same dilemma that everybody's having about human resource shortages and resorting to lower levels. And I think it's a question we're going to have to ask. I mean, ultimately, it is going to be, let's look at the total resource question without getting stuck in that question, because ultimately a good family medicine approach should include community health workers, and any good community health worker approach should include family physicians. So I think it's just about exploring how that configuration can work in different settings. Is that, do you think, a solution, Jeff?
Yeah, I think so. I think also, you know, you have to marry being both. I think you need to figure out how to do both in terms of being realistic to current conditions on the ground and being aspirational to fixing the problem, right? If you can't do both things, you never get to where you really want to be.
Yeah. And I think that everyone that has said, you know, that it needs to be contextualized, in a way is saying, let the document speak better to my setting, which I think is really true. And I think we're going to have to fight that, find a way to make it even more and more applicable. And I think there've been really great suggestions, like Joseph has said, you know, to look for African examples. And we're going to have to really, we've asked for it, and it's not been forthcoming as much as easily as we've asked. You know, they're just not, people are not sharing. But we need to just get more of it. And I mean, those African examples could be small little blocks in the document, you know, that could be part of the way we construct the document so that it shares some of these ideas in real ways. It doesn't need to fit into the sort of flow of a policy document, but can be referenced in the document itself. So I think there have been sort of great ideas on how to do that. Umar, you have raised the question, about training on prevention and promotion. I think the question is that, what do you see? And I think you're debating it with the Mercy, when you say clinical approaches alone cannot address the patient's needs and reality, I think it also comes from, maybe let me ask, do you want to share that, clarify, Omar, and then maybe Mercy can respond to it?
Yeah, what I mean by, thank you so much, Abisha. What I mean by clinical, I mean these are the procedures that are exclusively clinical. Why we should strictly by those in the clinics per se. And what I mean by the promotional and preventive, those can be taken outside without drugs being involved. So that by mere advice and talks and other things can be, a problem can also be solved. Some problem can be emotional. Some can be just a simple anxiety. Some can even be hysterics. But what I'm saying in general, the three must be combined together. None of them can be able to work in silos. That's the issue of multidisciplinary, transdisciplinary, and interdisciplinary. So they all have to work interwovenly. That's just my suggestion. Thank you.
Absolutely.
Yeah.
Perhaps Mercy can respond, and then I can just add, again, citing the example of where I work.
Thank you so much, Prof. Shabir, and thank you, Umar, for bringing that up. And I think, as Prof. Shabir mentioned, that is something also as AfroPHC we are trying to address in designing the postgraduate family practice program for different cadres, because mainstream and so far most of medical education focuses so much on the clinical. But now when you come to how you train the family doctor, the family physician, the family nurse, our focus is on what we call the biopsychosocial approach. That is one. We approach someone from the point of an individual living within a family, living within a community. That is another one. And we also look at the community in terms of the socioeconomic determinants of health, including the environment and climate. That is how, like, for instance, for me as a family physician, that is how I was trained in Cuba to practice medicine and to take care of the community. So I do agree with you. There's a lot of focus on the clinical, and that is what now is bringing the importance of maybe the family doctor, the family physician within the primary healthcare system, and general practitioners and nurses and other cadres who are trained in like the family medicine kind of approach to practicing medicine. So I do agree with you 100%. We should not just focus on the clinical. We need to look at everything from a holistic point of view. And we're hoping that this document and all the other work that AfroPHC is doing will change that kind of undergraduate training into something that is, one, interprofessional, and two, also takes the biopsychosocial approach to healthcare. So thank you for bringing that up, Omar.
Thank you, Omar. I would stress, have a look again at the document. I referenced the Shawala community practice, and there's an article that is there. We need to actually make all of this much more easy available. It's, I think we'll have to put it with the document, like we have these appendix. We'll have to create these so that you have easy reference to it, so that you can see places where you can do exactly that. You can avoid the siloed thinking, and it is not easy. I mean, I'll just quickly share before Innocent speaks, is that I work with, I set up a community practice in Soweto, and we get interns. These are newly, literally almost newly minted doctors coming through every 2 weeks, and they spend time in the practice because we want them to appreciate that, don't have this blinkers and think biomedically and just treat people. And they come with some education at the medical school saying family medicine, but they don't see it in reality. We want them to see it, where you have a relationship with a patient where you can think beyond just the clinical, you have the psychosocial issues, and we actually help them to consult better. to do the right thing with the patient, and they tend to do that quite well. But in this setting, we feel that they do that, but they still have the mentality of an individual consulting across the table with no link to the actual family and the actual community. And we have to really tell them repeatedly, and it's knocking at the door all the time, that, you know, here's the system we've created for you, where we have a family folder where you see everybody as a family. Even though you're seeing one patient, you'll get the whole folder. In terms of looking at that individual patient, you're looking at the patient from a preventive right up to a rehabilitative point of view, because the record keeping system encourages that, and we can look at the details of it. And then increasing in that process, we stress we have a community health worker folder, which has information gathered by that community health worker in the community about that family, and a whole bundle of social determinants are there. And we say to that person, as you interact with this patient, please look at that family, and when you interact, engage with the community health worker, a conversation about the community health worker, and try and link the community health worker care in the community by referring the patient to the community health worker. For example, I don't have the time to explain to you, but you need to be able to deal with all the allergy problems, but there's a whole long list of things you have to do, or diet, or you need to actually, you look like you're very stressed. I'll tell the community health worker to come visit you. And if there's a social problem, they'll link you up, or they'll actually have strategies that we've discussed on how they might be able to support you in the community. Doing exactly that. And I can meet with the community health worker, or they can just knock on my door and say, Doc Prof, you know what, this patient we went and visited, but we're struggling, or there's a challenge in circumstances, we tried this, it didn't work, and we have a meeting regularly, and a meeting anytime. That's community health. That's teamwork that I think is possible anywhere in Africa. Of course, maybe not the configurations of exactly how many people to which mix of things, but that teamwork is utterly important, and it can work. And there's plenty, the system needs that we are trained, we can be trained, and we could do that pretty well. So Innocent, go ahead.
Yeah, thank you so much. And I want to really thank everyone for raising pertinent questions and providing useful insight to those questions. And I think we agree that there is no one way of solving these complex issues that we are dealing with, but you just have to start somewhere. And I think we are starting. Just to make a comment, particularly on emphasis of PHC on clinical care. And I think traditionally, the beginning of modern medicine and modern health care really focused on disease. And it is always difficult to break the tradition. But I think what we need to appreciate is that you cannot have strong primary health care where the clinical services are actually weak. And if you take some time to look at the PHCPI conceptual framework, which I think Jeff has been working on with the colleagues, you will notice that service delivery is really one of the key components of that framework, which stands out. But I think what we need to appreciate is that, yes, we need clinical services, but the clinical services alone will not be enough. I think if some of you have read the Lancet Commission on the social determinants of health, there is always they are finding there has one important statement they make, that it is of no use for you to treat patients who fell sick because of their living conditions and send them back as the same conditions. And that is what brings the two together. That much as there is a focus on the clinical services, we must start the conversation on how we need to focus outside of that black box of clinical services. And we say clinical services are not enough, but we really need the whole conceptual approach to high quality primary health care with quality clinical services. And I think here training comes in handy. And like what Shabir was talking about, one of the key problems in the medical training, in the training of health professionals, is that the challenge has been on they don't focus on the broader issues that affect health and health care. For example, in the medical schools, people are trained in specialized units. You are in pediatrics this period, you are in surgery this period, but you're not training to be a pediatrician, you're not training to be a surgeon. And you actually find that when you look at the amount of time dedicated to community health and other population-based subjects, the time is so small. Yet when these big people graduate, the most of the issues they will deal with will actually be community and population-based. Same thing, when you look at the curriculum of very many health professionals training institutions, they actually don't pay very few pay particular attention to leadership and governance, which is now what we are grappling with. It is why would we say that the doctor should be the leader of the primary health care team? Probably it's because of the reasons I've talked about, the most trained, the most qualified, with many other factors around. But I think the question is, do we have evidence that the doctor, he will be the one best suited to lead the team? I don't think anybody has an answer to that question. And that is why we now need to really also pay particular attention. Our training institutions, how much attention do they pay to leadership and governance for health? And I think for effective teamwork, that is why all of us should start looking at interprofessional education. We cannot assume that these people are going to be trained in their silos, and then when they're in practice, they come together. So I think we have to keep the conversation alive, and we probably have to find a way how to deal with each of these issues one at a time. But I guess once we maintain the conversation, we shall have the green light at the end of the tunnel. Thank you very much.
Thank you, Innocent. And I think we're going to be rounding up. Most of the conversation has begun to dry up. There are no more comments. So perhaps we can get a round of comments from our panelists and senior leaders, and then we can close. So let's start with perhaps let me say, Jeff, you are the only. Joseph, perhaps you want to start. I think you, Joseph left. Joseph, here you are. Do you want to just start with some, or end with some comments, some overall sort of take-home message from this, and then we'll go to Jeff, and then Innocent, and then Francoise perhaps wants to have a word, or perhaps we can give Francoise a chance as our deputy. Okay, go ahead, Joseph. Is Joseph? I'm going to also ask Mercy to also give a few comments as a senior part member of the executive coordination team. So let's, Joseph, are you able to unmute yourself? All right. Let me start with let's ask Francoise. Francoise, do you want to make some comments? I'm not sure that we've got the right connection for you to speak. Francoise is the vice president of the organization. So Francoise, are you able to unmute yourself and just say anything? Yeah, go ahead. Please proceed.
Yeah, good afternoon, everyone.
And just a quick introduction. I think you haven't been speaking, so maybe people don't know you.
My name is Mwabufo Nenju Francoise. I'm from Cameroon, and I'm a registered nurse midwife with a postgraduate certificate on the family practice and a public health worker. I also work very close to the community, so I've really been passionate about what we are doing here, knowing where we really started with all this. I work very close with the community and the primary health care settings, and so it's really been an exciting 2 days talk, hearing from the rich experience you all bring from different contexts, from different communities. We've noted all your inputs, and we are going to really put it down. And I'm thinking again, after putting things down, maybe we'll have a review again of the document. But we want to sincerely thank all of you for participating. It has really been a rich time with you on this policy document. And I think it was worth bringing it out so that we hear from you all and before we finalize on the documents. So I just want to thank you all for your time which you gave for this program and all the rich contribution. I'm very excited about it, and thank you all.
Thank you, Francoise. Appreciate that. And I think let's go through then Mercy. I hope Mercy, and then Joseph, if you can unmute. Go ahead, Mercy. Some closing remarks.
Thank you so much, Prof. Shabir. I think the past 2 days have been amazing for me, just listening to people and their passion and the work that they do and their willingness to contribute and work on something that is for them, by them, because everything that comes into this document is from the policy workshops. So just to say thank you for everyone for always showing up. Showing up is very important. And then also speaking up and letting your voice be heard. And that for me has been a very great experience. So thank you, everyone. Keep showing up, keep speaking up. We still have our monthly policy workshops. Yes. So keep showing up, giving the contributions and keeping the discussion going. So thank you very much.
And I think I'm really appreciative of Mercy for running those policy workshops now, and she's doing that without any real help from me. So thank you, Mercy, for being such a great team member. Joseph, I know we have Biftu. Biftu, you want to make some comments? Go ahead. I think you can unmute yourself, and then we can see if. Go ahead, Biftu. Perhaps you can pull your screen down so we can see better.
Thank you very much, Professor.
Yes.
And maybe, sorry, sometimes our interruption due to power. That's why I couldn't follow. Maybe I'm happy with what everybody's saying. That's very good. That's very important. I also have a concern in terms of a frontliner concerning Ethiopia, because Africans, when we are talking about the policy, about documentation, we need to be able to talk the same language. And we have to know. Someone said a lot, someone from Nigeria and others also saying a lot about this issue. Maybe if you see generally as a national in Ethiopian context, physicians do prescriptions centrally. But when you go to the periphery, nurses are doing the same thing without being licensed as a prescriber. This is a very critical issue. One. Another issue is maybe to be discussed, maybe if no one knows about it. Another one is issue in terms of leadership, which is maybe has to be critically taken into consideration. When you see Ethiopian context, having nurses, pharmacists, laboratory technicians or technologists with a better experience in terms of leadership, medical doctors who are coming from the school are becoming leaders for the hospital, which is really very bad. By virtue of being physician, without having any leadership skill, they become medical directors, which has to be really properly discussed when we are coming in terms of leadership. I don't know other African country experience. I'm talking about Ethiopian experience. Maybe this has to also come into consideration. Otherwise, I'm very happy because this is where we can bring things on board and discuss and bring on solutions. And the good thing is maybe through the discussion, we can solve problems, and through time, we will reach on consensus. And thank you very much. And maybe sometimes whenever we need to talk, you better allow us in between, because when someone raises issues, we need to ask it to have a say virtually. Thank you, Professor. Thank you very much.
Thank you. Thank you very much, Biftu, for that contribution. I think we'll have to find ways to incorporate the question of the clinical tiering. I think, like you mentioned, prescribing. I think we'll look at some of the issues. So thank you for that comment. And we'll certainly take that forward to make sure it's clearer. So let's get some closing remarks then from our panelists. Joseph, Anna, I'm hoping you're able to unmute. Maybe Jeff, and then we can close with a closing comment from our president. Joseph? Jeff, I think Joseph's having a challenge. Thanks.
Sure. I think really great to hear this discussion, and I think the debate around a few of the issues, in front of you as you're trying to refine the document. And I think I would just return to kind of encouraging being able to both put forward a vision for how to deal with the now, as well as where you want things to go. I think if you could help spell out that trajectory for what you all would like to see as the future of the health workforce in the region, that again, that would be a really valuable addition to the dialogue.
Conversation. Yeah. No, thank you. I think that's a useful remark. You made that before, and I think we need to keep that really, really. Sorry, Omar, do you want to say something? I know you said you raised your hand, but I didn't see any hand raised.
No, I'm just trying to respond to Big Tom. He complained that he wasn't given a chance to. I was advising him he should indicate by raising hands. 1 year so that he will contribute.
Okay, I see he's left, but the hands usually pop up at the top, so I'm looking at it, so I'm not sure what happened. Anyway, apologies for that. Thanks. So thanks, Jeff. I think that's a really pertinent remark, and I think we certainly are going to be taking this forward. Let me perhaps do that before we get the president to make his closing goodbyes and farewell for us all. We are basically going to take this document forward. Clearly, there's been lots of input, very useful discussion. We need to be able to assimilate that and find ways in which we can refine the document. We are trying to get a team based with the president and deputy president, as well as Jeff Markins, Joseph, Anna, and Champion, the panelists that we've had, even Humphrey from WHO, if we can draw him into it as well. We want to be able to fine-tune that document. We don't expect to fine-tune this next version. We're going to just try and build it up. We also will then circulate it again, and we are hoping to go through a process of taking it to as many different places across Africa so that we can see if it can be tested for its contextual ability. Can it speak to everyone without getting stuck in the individual country's sort of context? But people see it as connecting to themselves, given their realities. And I think taking some of the really useful ideas of, referencing, using African examples, and also looking at it, the now, like Jeff says, the solutions for now, vision for now, and a vision for the future. So I think there's a suggestion of having a family picture. I think that's a great idea, Eli. If we can all put on our videos, and I'm going to trust that any number of people, so if you can put your video on or picture, show us your picture, and then we can just take some quick group photo and keep it for posterity. It really would be super. Mercy, will you do that? I think, and Eli, I'm going to just we'll just give people 2 seconds more. I think they'll pop up on the first page, as many as possible. Wonderful, wonderful. We need a full page of real people. Great, great. We're almost there. 1 page full. So great, great. So let's just take a picture of everyone here. And on the first page, great to have you all here. And then let's see of the next page. And I think that's it, 2 pages worth. So we have you. We will post it on social media and speak of this event and what you've been able to achieve. So thank you all very much. Hope you've enjoyed it. So let me hand over to the president So as I said, sorry, before I'll hand over, I just want to say that the process of engagement will be still over the next few months. And then we're hoping to pull it all together once more with the advisory board and the executive board sometime in September, October. And from there, we will hopefully then launch it or use it in different ways, as had been suggested, to create a thematic document that is then geared towards different stakeholders. And then we will be pursuing the angle with the WHO of getting it tabled in a way as being contributions to build up something of a similar document for the WHO Afro and to engage with them. So let me stop there and hand over so you have an idea of where we're kind of going at. But let me leave it to the president to close this conference formally. Just a reminder, please, all AfroPHC members, the AGM is tomorrow. Please go look at the website and you'll see the details of the meeting tomorrow. And we hope to see you there tomorrow. Over to you, Dr. Besigye.
Yeah, thank you very much, Professor Shabil. Really, my last comment is to thank everyone for sparing time and attend this 2-half-day conference. Special thanks to you, Shabil. It is really through your efforts that this has been able to be pulled through. Of course, Shabil, as our executive coordinator, is really responsible for the day-to-day running of AfroPHC, and without his efforts and his input, I don't think we would still be a living organization.
And the team, so don't forget the team.
Of course, yes, that is. So my second on the list is basically to thank the executive board, because the executive board really works hand in hand with Professor Shabil, and we are really very grateful, particularly for those members who were able to be present for all of the 2 days. And I think we have the new group, which is the central coordinating team. I think Mercy has been here. It is quite evident that that is one of the key living organs of AfroPHC, and we are really very grateful for all that the Central Coordinating Committee is doing. And I really want to thank all of you, particularly those who asked questions and those who provided some insightful comments to answer the questions. And above all, special thanks to the panel members. The panel was fantastic. And as you notice, it was really composed of people from diverse backgrounds, from different parts of the world. And I think we have a broader understanding of things because of the nature of the team. And the members, we appreciate that we are dealing with complex situations, but at least we are beginning. And I think we should keep this conversation alive and maintain the momentum so that we don't really lose our baby with the bath waters. So I always encourage you, whenever you see the emails, sometimes the emails may be too many, but please respond, because we must work together to achieve what we want. Once again, allow me to congratulate all of you for finishing these 2 days successfully. The attendance was really quite good. Every day, yesterday we had over 50 people. Even today we have over 50 people, which is really quite a good attendance. And from mainly, I think every region on the African continent is represented. And at this time, allow me to extend special thanks to our participants from outside Africa. You always bring in quite useful insights. And I think if you have noticed, Jeff from PHCPI has been quite instrumental. And this is, I think, one of the global organizations that is having special focus on primary health care. And even in our board meetings, he really gives us a lot of insights. Special thanks to you, Jeff, and we are really very grateful for all of your support. So members, with all of that, I declare this conference officially closed. Looking forward to meeting all of you at the AGM tomorrow. Thank you very much. Have a good morning, a good afternoon, and a good evening.
Bye-bye, everyone. See you tomorrow. Please join AfroPHC and join us tomorrow. So please don't forget, if you are not a member of AfroPHC, go join afrophc.org, join us and see us tomorrow.
Okay,
bye-bye, everyone.
Bye-bye, bye-bye.
Bye, everyone. Thank you.